Today, as our guest, we have Dr. Ciaran Fairman. Ciaran is an assistant professor at the University of North Carolina. Dr. Fairman's primary research focuses examining the impact of exercise, nutrition, and supplementation interventions during and after cancer treatments. He is also the host of the REACH podcast and the director of the Exercise Oncology Lab. Thanks very much for joining us today, Ciaran. Just to kick off, can you give us a brief introduction of yourself and your background?
Yeah, so my name's Ciaran. I'm an assistant professor of exercise science at the University of South Carolina. And my main role here is to act as the director of the Exercise Oncology Lab. So what we do is basically look at the role of exercise and nutrition during and after cancer treatments to kind of mitigate a lot of the side effects that we know kind of happen from both the cancer and its treatments itself. So I've been here about 2.5 years now, absolutely loving the role, really enjoying the research we're doing. And you know, thanks to lads like you, I like to do a lot of outreach as well, and try and get our research out to a broader audience and get people aware of what we're doing.
Great. Very good. And Ciaran, what motivated you to go into exercise and the oncology field?
Well, exercise in general was because I wasn't smart enough to do anything else. And then well, to be honest with you, I played sports my whole life, and it was kind of the only thing that made sense to me, or the thing that I was most passionate about, learning about exercise physiology. And originally I was in the area of strength and conditioning, and I had ambitions to go on and do that for a career. And I was in the MLS and doing some professional stuff, and I really enjoyed it. But I felt that there was kind of one, I was just very small fish in a big pond. The strength and conditioning science field is huge, and there's a lot of really great people doing good work. And at the same time, my own mom got breast cancer, and I was away at the time, and I was kind of listening to everything that she was going through in terms of her own chemo and radiation and all the rest of it. And if you line up all the negative side effects that we know happen with chemo and radiation in particular, they kind of line up directly with all the positive effects you would expect from exercise. So it was kind of a no-brainer to put the two of them together. And then once I started to research that in general, I found out about the field of exercise oncology, that there was a boatload of researchers doing work in this space. And the really cool thing I think about it is that there is very little difference between training an elite athlete and training someone with cancer, because you have to be so careful about how you're prescribing the training load, how you're picking different training programs for specific outcomes, how you're managing rest and recovery, and how you can complement that with nutrition and other components there as well. So it was a fairly smooth transition. But then what is most fascinating about cancer to me is that it's so different based on the type of cancer you have, the stage of cancer, what treatments you're receiving, either in individual treatments or combination of sequence of treatments. And the puzzle of that and putting those pieces together and trying to come up with the proper solution in terms of exercise and rehabilitation is fascinating. And I think the biggest thing I'll say about it is it's the most fulfilling thing I've done in my career. You know, I've worked in a lot of different settings, and I think there's something unique about a cancer diagnosis that you hear the usual, like, you know, it's a new normal and people have a different body after their cancer. And in my experience, relative to some other chronic diseases, it tends to be the one that has so much impact on both the person and their caregivers. And oftentimes when they're going through treatment and all the rest of it, they're just full of, you know, appointments that are stressful, and all the stress and worry about cancers coming back and all the rest of it. Whereas we can be pretty much one of the only sources of positive influence in our life. And that is such a privilege to be able to be in that space and give that to them, you know?
Yeah. I know a lot of our listeners will be interested in hearing about the academic evidence supporting exercise. You know, could you kind of talk us through that? Just give us an overview of what's been published and
yeah, absolutely. So to give you the overview, it's almost worth giving you the history in the sense of the field of exercise physiology is brand spanking new relative to other fields. So you're talking about maybe the 40s and 50s where stuff really started to kind of bubble up. And then as far as the field of exercise oncology, the first study was published in the late 80s. So you're talking about 30 plus years of evidence. And so it has to be put in that context that we're such a new field that it's going to take time to build the appropriate amount of evidence. And with all that being said, you know, in the 80s, you're talking about people getting heart attacks and told to be on bed rest. So it's not like it is now where we have structured cardiac rehab programs and all the rest of it. So of course, if someone's getting a cancer diagnosis in the 80s, they're absolutely going to be told to rest from chemo and all the rest of it. And because there was much less understood about the interaction between chemo in particular and exercise, so much concern was around safety. So the first, I'd say 10 to 15 years was really centered around safety and can people do this? What is it doing to their bodies? And is it causing any adverse or side effects? Is it interfering with treatment? And fairly consistently across the board, we're seeing that it is safe, either during or after treatment, that you're not necessarily seeing any adverse effects on the treatment in particular. The caveat is that you will absolutely get the usual knocks and all the rest of that happens with exercising for months on end. You know yourself, like just training away, you might get a strain here and there. So that's kind of standard. But as far as interacting with the oncology treatment plan, no problem. The important second asterisk there is that our evidence, especially up until the past 10 years or so, has been predominantly in breast, some lung, prostate, and colon. Because they're the most common cancers, they tend to be the easier to recruit. And because they're the easiest to recruit, we can get a larger body of evidence quicker. So there's much less known about, say, head and neck or pancreatic cancer. And so I would also offer caution in some of these more rare or aggressive diseases. We don't necessarily have a lot of evidence on the safety. And so some of us are still doing that work now and trying to build that body of evidence. But as far as breast and some of the other things, the field has certainly moved on to where we're at a point of effectiveness. And then the immediate next question is effectiveness for what? Ultimately, we care about quality of life. So that's kind of one of the most consistent positive benefits of exercise, both during and after cancer treatment, that we see improvements in health-related quality of life. We certainly see improvements in fatigue, with the exception that we haven't done a great job so far of specifically enrolling people with documented cancer-related fatigue, which is, of course, different than just being tired in general. And now what's really exciting is that we've kind of built a really good body of evidence around functional outcomes. So in general, if you strength train, you're going to get a bit stronger. If you do cardiovascular training, you at minimum will maintain your fitness throughout treatment, if not have some improvements, which is great. And now we're at a point to see if there's an interaction, a positive interaction between exercise and treatment, where we can potentially enhance the delivery of chemotherapy during treatment. And I'll pause there because we're nowhere close to having a comment. The hypothesis is that cardiovascular exercise in particular could normalize tumor vasculature, which could help the delivery of chemotherapeutic agents and then potentially enhance the efficacy and lower the toxicity of the drug. So there's 4 ongoing randomized control trials, they've just been funded, so they will be ongoing, and we'll have that evidence in 5 to 10 years. But that's kind of where the body of evidence is going, in that direction. And then the other thing I'll say, kind of in balance to that, is that we're starting to move a little bit away from tumor specific evidence. So we would traditionally go colon versus breast versus lung, and you kind of recruit specific tumor types. Now we're moving more towards impairment driven interventions, in the sense of cancer related cachexia, this aggressive muscle wasting that happens during a variety of different treatments. There are certainly instances where the mechanisms of that muscle wasting condition will be different across treatments. But ultimately, from a lifestyle perspective, your intervention is going to be fairly similar. We're going to want some sort of anabolic intervention in terms of resistance training. We're probably going to complement that with, some sort of nutritional intervention, whether that's high protein diet, whether that's enteral and feeding tubes, or whatever we can do to kind of just arrest or stop that muscle loss. And ultimately, that is to say that like I mentioned before, we've got cancer-related fatigue, we've got lymphedema, we've got peripheral neuropathy, all these impairments that we know are happening from treatment. And traditionally, we've just lumped a boatload of different people into groups and kind of done a sub-analysis as an afterthought of, oh yeah, these people improved. Whereas now we're seeing a big need to say, right, in people with cachexia, what can or can't exercise do? And I think that's the next frontier of what we're doing in trying to really see what we can do in these specific impairments, because they're the most, especially in the context of cachexia, ultimately that's what people are passing away from, you know?
Yeah. Yeah. Okay.
And is it from the standpoint of just focusing on the problem, I suppose, the issue that the patient has in terms of their muscle fatigue, as opposed to the treatment? Is that like, do you feel that's a better way of kind of getting research and getting trials up and going, as opposed to looking at the treatment itself, new treatments that are coming on board? Because it's like, it's changing every year.
Yeah. Yeah. Do you know what? You're always chasing your tail to kind of match some of these treatments, you know, particularly with immunotherapies and target therapies now. We know much less about the interaction between exercise and those type of treatments. Yeah, I think that is a way of going around it. The other part of that is that there is really profound impacts of cancer treatments on physiology that we need to study that interaction too. So, for example, I'm fairly big, not big, but I'm really interested in the muscle space and body composition changes and things like that. And so there's some really fascinating longitudinal research. So metastatic colorectal cancer, for example, people will get a fairly aggressive. So metastatic is the spread of the disease. It's kind of gotten out of control and considered terminal. In that stage, people will get fairly aggressive treatments to try and stop the growth or slow the growth, or even just quality life management. If they can get to a point where they've kind of controlled it, they will go on to a maintenance form of treatment where it's less toxic and it's kind of, let's just keep things at bay. Yeah. And then at some point, the disease will progress anyway, and then they'll have to go back onto this more aggressive form. So what you've got there is a really interesting model of aggressive form of treatment for X amount of months, then a maintenance phase of a lower burdensome treatment, and then another aggressive phase. And we see patterns of body composition change in accordance with that timeline. So on the really aggressive treatment lines, we see a pronounced loss in muscle mass, a couple of kgs across a few months, which if you put that in the context of a 70-year-old female who was 50 kgs to begin with, that's a lot of muscle loss to lose. And then if you go onto the maintenance line, you see a level of spontaneous recovery without any intervention. So then when they go back onto the more aggressive treatment, they lose it again. So there's definitely something to be said there for the treatment alone is a huge driver of some of these negative side effects. And we have to be careful of overstating the benefits of exercise in those contexts. Because if I were to have someone exercise during that maintenance phase and they recover the muscle they were going to recover anyway because they're not in the toxic phase, and we're saying exercise is great, it increases muscle mass. Well, is it? Or is it they're just in this kind of recovery period where they're going to gain it back spontaneously? So we need to be very careful about balancing representing the evidence appropriately versus, and even being an advocate for exercise versus being an evangelist in the sense of exercise is good for everyone all the time, forever. It certainly can have some benefits in quality of life and fatigue and all the rest of it. But I've worked in front of and with enough people who have been in the end stages of life to say that, look, if you've got terminal disease and you've got 3 months left to live, doing a few squats, it may not be it. If you want to go and live by the lake and eat a load of pizza, I take the quality of life as a center focus, and we are a very small part of the supportive care package. And we need to be careful between having that advocacy and being able to say, well, if you want to, I can help you do it, versus you should. And if you're not, then it's you're doing something wrong kind of thing, and almost shaming people for not, you know?
Yeah. Yeah. That makes a lot of sense. Bringing it back to the trials and the question of clinical trials, like who typically funds these trials, and do you have challenges getting patients on them?
Yes, absolutely. So in Ireland, the Health Research Board is a big funding agency. Across the world outside of the US, the World Cancer Research Fund is a big funding agency. And then in the US, predominantly National Institute of Health or National Cancer Institute. So these are all generally government agencies that have funds available for a variety of oncology related research. It is exceptionally competitive and so difficult just to get the funding in the first place. For example, you know, I'm in this position now as at a research university, and you're talking hit rates of less than 5%. So
All
you're,
right.
you're thrown in, and especially in the States, you're competing with, I mean, hundreds of other applicants who have the same experience and have the same ideas and all the rest of it. So you really have to be at a high level to be able to compete. I say that because I haven't got anything yet, so I'm still working on it. But even once you get the funding, again, I would say breast is the easiest because there's so much awareness around breast cancer and activity. The treatments are so good, and even the detection is so good that people are getting caught earlier, they're getting treated better, so they're living longer. And that tends to be an easier cohort to recruit. Versus, say it's stage 2 or 3 pancreatic cancer, that accelerates out of nowhere. You know what I mean? And it can be a really progressive and aggressive disease where you also have to humanize it and say, okay, we need clinical trials, but hold on a minute, who's going to sit in the hospital when someone gets this devastating diagnosis and maybe they had a pain in their body for a few weeks and then out of nowhere they're being told they've got this aggressive disease and have to go into treatment next week. How are they going to keep their job? Who are they going to tell? So there's a lot that goes on in this person's life for us to come in and say, okay, well, also you're going to come back to the center 3 days a week and train with us. It can be a really difficult area to be in. And then on the other side of treatment, you could have, diseases that don't have necessarily long survival time. So we do a lot in lung cancer, and the survival rates are improving, but you're still, if you average stage 1 through 4, you're looking at about 40% survival rate for 5 years. So when we're trying to recruit people who have previously been treated for lung cancer, we're trying to look at long-term impacts of the disease and how we can help people recover. Oftentimes people have passed away, they've lost contact information, you've moved away. So it's a really, really difficult area of research to be. All that is to say that it doesn't mean it's not important. And in fact, I would say it's even more important. It's just, you have to have pretty thick skin when you're running some of these trials to kind of deal with some of these challenges as well,
Yeah. And in terms, like I saw on your profile that you're working to disseminate your research, and trying to implement it into practice. Could you just tell us a bit more how you're doing this across platforms?
Yeah, so I have my own podcast that I should get back off the ground. It was going for a while, and yourselves trying to maintain it. So that it's called REACH, Research and Exercise in Cancer Health, and that was started during my PhD studies with the same motivation in that, look, no one's reading our scientific papers. We're writing papers for each other, and that will eventually become a part of a large body of evidence that will inform policy, and that's great. But in the meantime, there are literally millions of people who are missing out on potentially beneficial lifestyle interventions because we are only going into these academic venues to talk about our work.
Yeah.
So I kind of made it a strong point of mine to develop ways to get myself out into the community and start to talk to people that need it. And ultimately, it was kind of centered around, my ma got diagnosed, 15 years ago. Can she even understand a paper that I write? Not a chance. So I also it needs to be at a level that she can understand and appreciate and all the rest of it. So that was the driver behind REACH. And then the second aspect, so I do a lot of that stuff. I'll do a community outreach. I'll do it, various podcasts and all the rest of it. And then the second aspect that I'm really passionate about is that I am very time limited as an academic, and so much of my pursuits have to be in the area of research and all the rest of it. And look, I'd love to have a global company that has consulting for all the rest of it. And I can't because I'm time limited. What I can do is partner with various companies. So there's a phenomenal company here in the US called Barbells for Boobs, which does a lot of lifestyle interventions after breast cancer. And they're partnered with 700 gyms in the States. And we work to develop some education materials for their coaches that acts as a certification to say, if you've gone through this program, you have a general understanding of the pathophysiology of the disease, the various treatments that people with breast cancer receive, the side effects, and help them modify exercise. And I'm involved in a few different initiatives like that I think it's such a big passion of mine to be able to go, I could never reach 700 gyms in the States. But if you've got the resources and infrastructure, and I can just share some of my knowledge, again, in a way that's digestible and all the rest of it, then that's the best case scenario. I can tip away at my research and have people that are better than me in that space and really kind of reach the masses with it as well.
Yeah.
Just a caveat that just in terms of I suppose you're reaching out to patients in that respects, gyms, which is fantastic. Like, what's your focus in terms of getting that information to, I suppose, HCPs, oncologists, oncology nurses, and possibly younger oncologists coming into the space?
Yeah, I mean, it's definitely challenging. Well, the you know yourself, like trying to get people to go to continuing education can be difficult.
Yeah.
Getting the accreditation so I used to do some workshops both in Ireland and Australia, and they were going for a while, but that was one of the limiters where people were like, well, is this accredited by X place, so it counts towards continuing education? The one thing of what I can say that I do in my day-to-day is that I've established some various college courses here on campus for us to, under the umbrella of exercise oncology. And so that's open to med students, that's open to a variety of people. And the goal is to continue to grow that, where it would become a master's level course or whatever. Or even, there's a crowd in Trinity in Dublin that are doing phenomenal work in this space, and just collaborating with various people like that anything I can do to share the knowledge with people, to your point, that we're going to catch earlier in the education system, that they might be tuned in. Because you can't because I used to be fairly, not aggressive is the wrong word, but fairly kind of adamant about, they're not getting any education. And you kind of go, well, have you taken any sort of cancer biology class and think about the level of intensity of the education required to be a good medical oncologist? It's only fair that they're getting 1 or 2 classes a semester on general lifestyle stuff. The stuff that is their primary job to treat the disease is so intense.
Yeah.
And there's also a very strong case for our field for the last 5 or 10 years, it's shifting, but people used to be kind of up in arms about, why aren't they talking about exercise? Why aren't they talking about nutrition? And it's kind of going, you've got an oncologist who sees 45 patients a day. When do you want them to talk about exercise and nutrition, especially to someone who lives out in the Ring of Kerry or some rural part of Ireland that doesn't have access to any of this stuff anyway? And so what we're also seeing is it's not, look, the awareness of the medical field is important, but we also have to build the infrastructure and support for them of like, right, you talked about it. Who can you refer to in rural Carlow to get someone any sort of support and resources? And how can we build maybe online interventions and support as well? So I think we need to take more responsibility of how we do that, as opposed to just kind of pointing the fingers at the medical field as well.
Yeah. So do you mean by targeting more materials directly towards patients, or kind of making it easy for physicians to prescribe exercise?
All the above. So I'll give you an example of one of the really great initiatives. I've got a phenomenal mate, Mary Kennedy, who's doing a lot of implementation science in Australia. And she was working in a radiation clinic that had an exercise service embedded within their clinic, and no one was going to it. And she did years of research and looking at a bunch of different things. And what she came up with was just automating the referral process, where we need to minimize the amount of decisions that oncologists need to make in terms of like, should this person or not be able to exercise? Let us make that decision. Refer everyone, make it an automated checkbox. As soon as you're checking off I did their vitals, I did whatever. Then I've hit the button. They get an automated referral to our services, and they get just an email like they would for any of their appointments. And that simple process alone, I mean, tripled the uptake and referrals to the process. Or it's developing materials that are relevant to, again, the farmer in Carlow or Meath or whatever is not the same as the person who's living in Malahide and has access to Trinity services. So we need to be able to also better tailor our materials to different people's lifestyle and culture and all the rest. So yeah, it's a lot of work.
Yeah. just what are the materials look like? Is it, is it someone getting in the gym with you, or is it like, a set of exercises you follow, videos, or a bit of both?
It ranges from the most, I would say, intense, but the most kind of time consuming would be, you're with me in the gym 2 or 3 days a week. I'm taking a full evaluation of how you move. I'm taking assessments of your fitness, your body composition, your strength. We can track them over change. We can identify deficits, and then I can work with you very individually to tailor movements. Obviously, that's a really, it can be a burdensome program for people to go through, especially if they don't have transport and all the rest of it. So an alternative could be like doing a Zoom session where we do either individual or semi-private groups where you're not getting as much individual guidance, but you're still getting some, and we can kind of keep you accountable. Maybe there's some weight management issues, and especially some of the more obesity-driven related cancers where we need more behavioral counseling involved there. Or it could be as simple as, you know, your pamphlet and here's X amount of exercise that you need to do that are beneficial. And you can probably understand that there's a range of effectiveness with those types. If you come to the gym 2 or 3 days a week, you're absolutely going to see benefits because I'm going to be able to spot anything on the go, tailor anything, and keep you progressing. If I hand you a leaflet and say, Kev, see you in 12 weeks, come back and when you did it all, that's going in the back of your car or whatever as soon as you leave the hospital. So we have to balance the effectiveness of the program with the scalability. And it's a fine balance between how you do that. The other side of that is also being able to appropriately triage people. So again, early stage breast cancer, where you might get surgery, maybe some radiation, but you're for the most part, you're good. You might have some local side effects from the surgery. You're good to go to most recreational centers and tip away with a personal trainer. Whereas if you've got kidney cancer or pancreatic cancer or GI cancer, head and neck, and you're going through treatment and you're getting chemo and radiation at the same time, and you're just trying to recover functional deficits, you need to be with an expert. You need to be someone who's trained in the area, who knows what you're going to experience and all the rest of it. So if we can balance the materials and support we're offering with the appropriate triage, then the people who need it the most intense care can get it. And then the people who just need almost a seal of approval, because there's so much fear still around, well, I had breast cancer and I had surgery and I was told not to lift my arm over my head. And now, then they haven't done anything in years. And if I just give you, listen, you're fine, you know, go to a PT, maybe you get range of motion back, because we'll see people who have had breast cancer 5-10 years ago and haven't lifted a gallon of milk or a few liters of milk over their head because they were told not to. That's a really safe guideline for the 4 to 6 weeks post-treatment.
Yeah.
That should not be the case for the rest of your life. You know what I mean?
Yeah.
So yeah, it's kind of a big puzzle. We're trying to solve all these different things at the same time.
Yeah. I just add to that then, I suppose, is trying to handle the mental, like, I suppose, different patients, I suppose, patients who might have had exercise in the past and those who never exercised in their life, and trying to motivate them into the same and trying to handle that and manage that, I suppose, is kind of difficult.
100%. And even coming back to the evidence. So some of the strongest evidence we have, particularly in breast cancer, is that we know all these deficits happen from treatment. You're going to lose strength, you're going to lose muscle, cardiovascular fitness is going to drop, and all the rest of it. If you have 6 cycles of chemo across 6 months and you train 2 or 3 days a week, the best case scenario, or a really good scenario, is that you are in the exact same level of fitness you are now. Because if you don't exercise, you can get so much worse. Now, try motivating someone who is 72, has never exercised before, and they're going to break their back 2 or 3 days a week in the gym, and they're not seeing any improvements. And you're kind of going, no, I swear this is a good thing. You know what I mean? It's really difficult. And I think what I love, so our lab in particular is really focused on resistance training or strength training, because, you know, a lot of people know how to walk, and it's fairly easy to guide that. But there's so much benefit that can potentially be achieved from resistance training that is functionally relevant. So again, the same 72-year-old who has a hard time getting out of her chair, that's your exercise. Let's get you up and down out of a chair a few times a day, a few times a week. Let's gradually maybe load that movement so you're getting a little bit of overload with that. And let's get you to a point where you don't have to be stuck in that chair when you go home in the evening. You can get up, you can carry your washing around, you can bring your bags in from the car, you can play with your grandkids. And that's some of the ways we try to make what's important to us in terms of like strength and functional outcomes relevant to them. I care that your strength improves, but you care that your strength improves because that allows you to play with your kids and continue on having a mobile life where you're not going into assisted living and stuff like that. So if you can make those connections, it tends to be a little bit easier to get people bought in.
Okay.
Okay.
Very good. Could you talk us through, exercise at different stages? Like, there's talk now a lot of prehab. I hear the word. I haven't done a lot of reading on it.
Yeah,
is it
absolutely.
like, do you do something different for prehab than you would like post-treatment and recovery?
Yeah, absolutely. So there's a phenomenal researcher up in Canada called Kerry Cornier, who he basically founded this PEACE framework, and it references all of what you're talking about, where we've got this prehabilitation stage of before treatment, then we've got this on treatment phase and recovery phase. Now, very similar to an ACL, we know if you tear an ACL, if you can strengthen the muscles and ligaments and tendons around that joint heading into surgery, your outcomes from surgery are so much better. You're getting back to playing quicker, you're getting back to full fitness better, and all the rest of it. The exact same theory applies in oncology, where we know if you get surgery and you're going to lose tissue, we know if you get chemo, you're going to have some damage to cardiovascular system or whatever. Can we get you to a point where we increase your fitness to buffer some of those side effects that are about to come? So it's about building up fitness to try and give yourself a better bank of fitness that you can afford to lose a little bit. Or oftentimes, and it's not oncology specific, people use metrics of fitness as a way to gauge if people are fit enough for surgery. So if your VO2, if your maximal oxygen consumption is below a certain threshold, people won't operate because they think the body won't be able to withhandle the stress. Or if your functional status isn't high enough, you're too low in resilience to be able to receive the stress as treatment. So can we get you out of that red zone so you can afford to receive the treatment? Now, here's where the evidence stuff comes in, because that sounds phenomenal on paper and I can make a really convincing argument. You keep coming back to, Joe Bloggs is diagnosed with lung cancer and it's stage 3. Well, they've got to get surgery next week, the end of next week. How much? And then, you've met with your oncologist and then I'm going to come in and say, listen, we're going to train you like 3 or 4 times in the next 10 days because you need to get your fitness up. You're like, hold on a minute. Like, how am I paying for this? What's going on? Where's the treatment? There's so much going on in their mind. So the prehabilitation space has a lot of potential, but that is probably the most difficult space to actually conduct high quality research in.
Yeah.
And so I think it will be a long time before we build the appropriate body of evidence to say that everyone should absolutely do it. I think there are certain cases, again, going back to like early stage breast or prostate or whatever, you could certainly get some meaningful improvements in fitness in that space. But it does have to be offered with the caveat that pancreatic, head and neck, like that, there's a really tight timeline, a really aggressive disease, and it's going to be hard to get people to do anything in that treatment space.
Okay.
So then you go into the on-treatment space, and really that's kind of what I mentioned before. Like a great outcome for people is managing fatigue, maintaining quality of life, and then getting you through that whole treatment phase where you're in the exact same position. If we can maintain the same levels of strength, the same levels of cardiovascular fitness throughout treatment, you're laughing. You've made it through treatment with no tangible deficits. Now, there's absolutely going to be impairments that happen. That's just a collateral damage that occurs with treatment, particularly say things like peripheral neuropathy. So neuropathy is, numbness and tingling and even pain in the extremities like the hands and feet. And chemotherapy-induced peripheral neuropathy it comes from specific chemo agents. So if you're going to get these platinum-based chemo agents, it's a high likelihood that you're going to get peripheral neuropathy. And essentially, the mechanisms aren't fully understood, but there's some sort of damage to the nervous system or the neuromuscular system. And why I'm saying that is that that's something that exercise is not really going to be able to fix. So when we deal with impairments, we either challenge the impairment or we accommodate the impairment. So if you lose cardiovascular fitness as a consequence of breast cancer treatment, we can challenge that impairment. We can get you back to a level of fitness that is good. If you have peripheral neuropathy, it's unlikely that exercise is going to fix the numbness and tingling in your pain or in your hands and feet. So we have to accommodate that impairment. So what that means is you've got balance issues. Maybe we put you on the bike. You have poor grip strength. Let's not do free weights. Let's do machines. So it's having an understanding of the impairments and when they're going to present and how they're going to present, so we can either challenge them or accommodate them. So, another example would be prostate cancer. Androgen deprivation therapy is the primary treatment for a lot of prostate cancer stages. And what that is a hormone therapy where testosterone is a key driver of prostate cancer growth. So the treatment is either stop the production of or stop the action of. So just cut it out. If you essentially castrate a man through treatment, well, then he loses all testosterone. He's going to have a ton of loss in muscle mass. He might start to accumulate or gain some fat mass. Bones are going to start to get more brittle, absolutely lose strength. So that's a really clear indication that, strength training is the goal there. We need to recover or maintain as much of that lean tissue and strength as we can, minimize fat accumulation and all the rest of it, and try and maintain the strength and density and composition of the bones. Or you've got breast and endometrial cancer tend to be more related to obesity and overweight, and becoming ending up with overweight or obesity doesn't happen overnight. Reversing overweight and obesity doesn't happen overnight. So you're going through treatment, and you may even get corticosteroids that help promote more fat mass accumulation, all the rest of it. So you've got women who are going through this really intense treatment and seeing their body change for the worse. And we're trying to deal with managing the side effects of treatment, but also introduce behavioral interventions to try and have a weight management approach and get them back to a body weight or a body composition that is going to reduce their risk of recurrence. So all of that is to say that that's the goal of On Treatment, is really kind of identifying based on the type and stage of cancer and the types of treatments that they receive, what impairments they're going to potentially have. It's just risk mitigation. How can we stop these from happening? And if they happen, how can we make them the least burdensome as possible? And then in the post-treatment phase, that's really where, particularly when some of the immediate side effects of treatment have subsided, in particular, like immune function status from various chemotherapy agencies. Once you get your immune system back, you can maybe start to integrate back into commercial gyms or local gyms. We start to integrate you back into society, and it's more just risk reduction for the future. How can we manage the recurrence of your cancer and just overall healthy lifestyle behaviors? And I offer that with the caveat that that's not the trajectory that everyone goes on. So there's absolutely the palliative stage too. And that is mostly quality of life. Can we keep you out of bed as long as possible? And can we make that time out of bed as enjoyable as possible? And that's a really difficult space to be, because, oftentimes it is, the disease is progressing to a point where people do pass away. And again, exercise is not going to necessarily delay that. But if we can maintain some degree of quality of life there, it means they can kind of stay out of bed and all the rest of it. And even to my earlier point, just having a laugh with them and being able to enjoy their last days and all the rest of it, I think is really important in that space. And then the last thing to say is that people can get 2 cancers at once. People can get recurrent cancers, and all that throws that timeline all out of whack as well. Particularly in disease progression where you might have bone metastases. So cancer is spread to the bone, and sometimes that can make the bone really hard and painful. Sometimes it can make it really fragile and brittle. So we have to be very careful about how we're managing that as well. And all of that, to my mind, comes under the umbrella without insulting people, because a lot of people who aren't in oncology just think of old, sick, weak. And that's not always the case. And they are human beings first. And if we put our fears on them and we're afraid to treat them like humans, and people see participants working out in their studies and they're sweating or they're deadlifting or doing all this stuff, and they're like, they've got cancer, they're on treatment. Like, so what? It's under, it's under supervised guidance with people who understand the consequences of all these treatments. We've come up with this plan, understanding all those things. So it's in a safe and controlled environment. It's okay for them to sweat. It's okay for them to have a good workout. And if you restrict them to a point, because I go, there's a window, there's a point at which people are concerned about safety, and absolutely that's important. But there's a very real concern on the other side of, like, you might bore the life out of people or insult them because you're treating them like they are so fragile, and they're a lot more resilient than we give them credit for at times.
Yeah.
Yeah, they have drive. They want to survive, I suppose. So they want to do what counts, you know.
Exactly. And especially Irish people, like you don't want pity. You know what I mean? Like your big country
Yeah.
farmer coming in from Mead and you being like, oh John, I'm so sorry. Get up out of that. Give me those weights and let me see what's happening. You know what I mean?
Of course. Yeah.
It sounds like it's very, very different between different types of patients have very different prescriptions in terms of exercise. I'm just wondering, for like a typical survivor of lung cancer, I have a family member who unfortunately suffered from lung cancer. Luckily she got through it, but she suffers a lot from fatigue. What would be something you would recommend for that?
Taking breaks. So we're actually doing some really interesting work in that space, in that if you were to test the capacity of people with lung cancer, the rate limiting factor of their exercise capacity is not muscle fatigue. It's overall fatigue or shortness of breath, because they've had some or part of all of a lung removed, or they've had radiation to the chest wall, and all those things leave them with this breathlessness and fatigue. And oftentimes you can be sitting there and going, well, I don't know what to do because there's no way I'm getting through a half an hour, 40 minutes of exercise. You don't have to. We developed this program that we're trialing now, even with resistance training. So if you typically think of a strength training model, you'd be like, whatever, 3 sets of 10. If you were to do 10 repetitions of an exercise, that's a long time to be doing exercise for someone with lung cancer. And they can quickly get out of breath and lose their breath. And that breathlessness is a very anxiety provoking feeling. And then you're like, I don't want that. I'm not going to exercise. But if instead of 10 repetitions, just do 2 or 3, take 15 to 20 seconds, even sit down, catch your breath, then do 2 or 3 more. You're not going to lose any of the benefits from exercise by taking extra breaks. And so, you can go as little as, if walking around the block is difficult for you, do a half a block and come back, or do a quarter of a block and come back. And I say that knowing that, that can be a pain in the backside for someone to go, well, I have to do this 6 or 7 times a day. But that's what we found to be one of the most powerful things for people with lung cancer, to accommodate the fatigue and breathlessness, because it's option A, I'm really tired, so I'm not going to do anything. Or option B, I have to work a little bit harder to find some ways to work around this. But the best thing about that is if you can do that over time, your fitness will get to a point where your fatigue dissipates. So your fatigue will be lower at certain activities. So if Mary used to get tired walking up and down the stairs, and we get you to a point where 3 or 4 weeks you've been walking around the block or getting up and down out of your chair, maybe now you're not tired getting up and down the stairs. And then you slowly start to kind of go back and forth with that. And you get to the point where, wow, you could get parts of your life back and be able to do some different things. And so I would say combining some variety of strength training. And again, it can be as simple as sitting up and down out of your stairs or out of your chair, doing some lunges, maybe some elevated push-ups on a desk or the counter or whatever. And it doesn't have to be long. It can be 10, 15 minutes, if that. Take as much break as you need to catch your breath. Sit down, enjoy yourself. And then if you can fill in that with the rest of your week with trying to get some walks in here and there, and then just listen to your body. Because if I was to say that now and you're going to go, right, well, I'm going to do 5 days next week, don't jump in at the deep end. Listen to your body, kind of gradually build it up over time. And if you're getting to a point where, geez, I used to not be able to stand out of a chair 3 times. Now I'm doing it 3 sets of 10. Well, maybe now we can start to incorporate some more exercises. And so there's also no rush to this. It's not like you need to get this back by next week. It's this, we can mitigate this fatigue over the course of weeks, months, and years. Let's have that time frame in mind. Let's find an activity you enjoy. Let's gradually build you over time, accommodate your symptoms, and then see if we can see some changes over time.
Very good. Thank you.
Very good, yeah. And just for any healthcare professionals who are working with patients on a daily basis, what simple steps can be taken to implement exercise in their treatment center? Anything at all? Any suggestions, I suppose, to?
Yeah, I'd say, I mean, we certainly need champions on the inside. We need people who are advocates of exercise services. And to be honest with you, some of the best people for that is physicians' assistants and nurses and chemo education folks, because again, the oncologists don't have time. And oftentimes they're not spending, you know, a nurse on a chemo ward, they're spending 3-4 hours with people on a weekly basis. And they're going to have such a better or more intimate relationship with them. So it could be starting a conversation of, hey, what are you doing in terms of exercise and lifestyle? You could also reach out, and it's getting better now, to your local community and see if there's any service in existence for people with cancer, or even trying to look at cardiac rehab is almost mandated in most places at this point. So leveraging some of those services and going over there and saying, hey, would you be interested in developing this arm or trying out this service? And then I think one of the most powerful things you can do is having a conversation of, you know, this could be positive for you. What are the things that's kind of in your way? And again, coming from a point where you're not trying to shame them, you're trying to understand their environment. Because a lot of times we'll do house visits with people, and the reason we do that is to try and understand the environments, because you know, it's too easy to assume that everyone has internet access. Everyone has a safe walking neighborhood and stuff like that. And so, especially in the States, we deal with, in the Southeast in particular, we deal with a lot of African-American women who don't feel safe walking around in the evening. So who am I to say, go for a walk? You know what I mean? Your neighborhood's not safe. You don't have roads, or you're African-American, you're petrified of whatever could happen, especially when it gets dark. So having, again, it, you know, I come from, I say clinical, but I just come from an applied background. I think the research is important, but those type of conversations are so meaningful to have with a person and treating them like a person, instead of just going, you should do this 2 or 3 days a week. And well, let's have a conversation. What can we do? And if it's not that, how can we get you the first next step?
Okay. And are there any good resources you could recommend, you know, like any websites or, you know?
Yeah, there's a ton that I could probably be better served emailing you to link in the show notes or whatever.
Yeah, that'd be great.
Yeah, the American College of Sports Medicine, Sports Science Australia. There's a ton of, like, American Cancer Society has a lot of great resources. There's some pretty good people who develop YouTube and free videos and stuff like that. So I'll send all that on to you so you have that as well.
Okay, great. We'll definitely have it in the show notes. So I have a couple of questions here from the community as well. So Dr. Giuseppe Banna, he had a question around how to recognize, monitor, and manage patients with tumor-related muscle and weight loss with exercise and supplementation. I don't know if you have a quick answer to that.
There's no quick answer to that. So I'll express the caveat. Defining muscle wasting is exceptionally difficult. Even when we talk about cancer-related cachexia, the general definition is, have you lost more or less of 5% of your body weight in the last 6 months? How often are people measuring their body weight that consistently to understand if they have? And then even if they have lost weight, is it just they haven't been drinking or eating in the last few days, or is it like this is a muscle wasting condition? Having said that, the best way to track it is balanced with what is the best way versus what is the quickest way to do in clinic. Because the best way is to do a CT scan or a DEXA scan and get a full picture of body composition. That takes a lot of time and it's expensive. A quick and easy way is to just track weight and just see how they're tracking. And in those muscle wasting conditions, even though you're losing muscle mass, if you're maintaining weight, you're in a pretty good position. So I offer that as a balance of, like, yeah, you could do DEXA and it'd be more accurate. You can get quantifiable muscle loss, but tracking body weight is probably good enough, especially in this we just got to stop this. And then as far as the exercise nutrition, most of it is going to be in that muscle waste condition, resistance exercise predominantly. So again, like 4 to 6 exercises, squats, lunges, push-ups, different things like that we can try and provide an anabolic stimulus to maintain muscle mass, and maybe support that with the appropriate supplementation, because a lot of people have difficulty eating. So there's like Ensure and all these kind of other nutritional supplement shakes. You could just do general protein shakes, and we could have a full hour and a half podcast on that alone.
Okay, great. We'll have you back
Yeah.
for that one.
Yeah.
Yeah. Another question from Giuseppe is, so far, exercise has been primarily measured by the number of steps. Is there another valid measure to adopt for trials at the moment?
Yeah, I wouldn't necessarily say, sorry, boys. I wouldn't necessarily say that it's only done by steps. Like in epidemiological work, we'll measure like step count or METs or minutes of activity per week.
Yep.
And I would say that it's a fairly good gauge. If someone's accumulating about 150 minutes a week, they're in a good shape. The problem with all those things is that they're ignoring resistance exercise. So again, balance it with, the most accurate way to do it is to walk into the gym with them and track their sets and reps and all the rest of it. How much more information are you going to get out of that versus merely 2 days a week? Are you getting to the gym? And that's the first best case scenario. You know what I mean? So,
all right. Yeah.
If you're getting 150 minutes and you're doing 2 days a week of any sort of strength training activity, you're in a really good starting spot. And then anything after that really is a bonus.
Okay. Super. That's great.
A question from Rohit of the Oncology Brothers. So he was asking, he did his fellowship in the area of exercise during treatment, exercise yoga and other supportive measures. And he was wondering, do you have any tips on getting more patients enrolled in trials? Is there anything you've seen that's worked?
Oh, if I had the answer, I'd have $1 million. I think all those challenges exist that I mentioned. I think it comes down to one, humanizing the experience, talking to them at a level where you're on their level. Like you're not coming at them and as if you're like above them or it's whatever. It's like you're going through this really tough and intense experience. This is something that we can help you with. Because oftentimes if you're in a comprehensive cancer center and they're getting their treatments, they have a list of 10 to 15 clinical trials. And they go, you're eligible for this, you're eligible for this, you're eligible for this. Which one do you want to do? And you're kind of like, what is going on here? What should I do? Recruiting for exercise can be a little bit easier. But again, if you're in a comprehensive cancer center, oftentimes the clinical trials are prioritized over these kind of supportive care interventions. But ultimately, it comes down to taking the time to speak to people. And oftentimes that needs to be, you have to have enough resources to be able to do that. So can you sit in the chemo education center with the people? Can you go into the chemo bays and talk to people? But it can't be, as bad as, or as poor as the pamphlets are for getting people to exercise, that's about as bad as hanging a flyer in a clinic is. How many people are actually going to look at that flyer and go, that's for me? It needs a personal touch. It needs people to understand how and why it can be beneficial, not just for exercise, but how that exercise translates into their daily life. And then the last thing I'll say is that a lot of people are getting really good results from incorporating caregivers into the research as well. So again, John from County Meath, and he's a big, strong dude. He doesn't want any help, but his wife will tell him to do it. You know what I mean? Or if you can bring her along to the program and do that kind of partner-based training, that can also help. So there's a lot of different ways, but oncology is so hard to recruit in general.
Yeah, I can imagine.
And he was also wondering about the funding side of it. And obviously it seems like that's challenging from one of your earlier answers. Is there any way that, to attract more funding to the space that you can think of? I
think it depends on the environment you're in and there's a lot it depends on, but the government grants are really, really competitive. If you can find, various foundation grants or various companies that are philanthropic in nature that might have, 20 grand here for a project or 50 grand here, and you kind of start to pool those resources, you could even do your own community-based fundraising. So for example, the Barbells for Boobs company I mentioned, they do a lot of donations and fundraisers, and their average donation is about $50, but they pull in a couple of million a year because they're so widespread across the country. So funding is again always a nightmare. But if you can try and identify some of those smaller pockets, the nice thing is that they're often overlooked by the bigger centers because they're chasing the $1 million grants kind of thing. So they tend to be a little bit easier to get, but 20, 30, 40 grand in clinical trials goes by lightning quick.
Yeah.
Okay.
Yeah. And just, I suppose this is a question, kind of a higher arching question. Like, are oncologists buying into physical training for patients? I suppose oncologists and oncology in general.
I've had pretty positive experiences, and I've seen it certainly improve over the time. And to be honest with you, Australia and Europe is absolutely better at this. So, for example, in Germany, people get 50 free training sessions if they've had a diagnosis of cancer. So that's the standard. That's the standard. You know what I mean? And in Australia, they get 5. Ireland, again, Emer Guinan's group at Trinity. There's some other people doing some really great work that Ireland's starting to recognize it too. So it's going to be a combination of policy almost mandating it from above and individual providers recognizing the importance. And I will say what I've seen, especially with kind of the younger generation coming through, is that there are a lot of really motivated oncologists who want to do the extra work to help support people through it. And I've certainly, you'll have some people who kind of may not view it as important or at least a priority. And I think it's just, again, trying to recognize what avenues are worth kind of digging your heels in, and who is it right in the oncology team. So-and-so is not in support, but there's another 4 or 5 people who are all about it. So let's focus our energy on getting them on board.
Yeah. Great. It's nearly a case of kind of bringing it into the treatment pathways. Well, the aim is to get it into the treatment pathway as de facto.
Exactly. Yeah. Like it's opt out rather than opt in. So when you meet to determine all your services, we're just another service that you're meeting. You're meeting us and you're meeting the registered dietitian, which would be cool because it's going to happen. You know what I mean? It's not a case of when or if, it's when. And some places will be sooner or later, but that's what's going to be cool about this, is that coming back to the original question of like why I'm in this versus strength and conditioning, I see that goal, and that's such a collective goal that all of us all over the world are working towards, and it's such a rewarding space to be in. It's going to pay off, and to be a part of that is really cool.
Yeah, brilliant. One final question. And another question from Dr. Bana is there any evidence in favor of exercise oncology in the prevention of cancer relapse?
Relapse is tricky because most of that is going to come from epidemiological evidence. And it's the same for prevention, where the most we can say is, look, if you maintain a healthy body weight and if you maintain an active lifestyle, your risk of, either getting cancers or recurring from certain cancers, especially the obesity-driven ones, is going to be a little bit lower. But randomized controlled trials, to say conclusively, they're very difficult. There are 3 RCTs, to my knowledge, that are looking at survival, which is insane that they're even attempting this. So there's one in prostate cancer, one in colon, and maybe one in pancreatic. But you're talking, especially in the prostate and cancer, you're talking about like 800 to 1,000 people involved in these or enrolled in these randomized controlled trials, and looking at 2, 3, 4, 5 year survival of people who exercise versus don't. And because of it's 800 to 1,000 people, it's years before you're going to complete the trial, and even longer then until you get the evidence. I hope that they'll be completed and we'll have some information in the next 5 or so years, which would be really cool to have an RCT. To help understand if it can, if it can't, what the challenges are, and so on. But that's kind of where we're at, and how difficult it is to do human. And you talk about funding, and because even if you're looking at 5 year survival rate, you're not going to recruit 1,000 patients on day one. You're going to enroll them in waves of X amount. So that 5 year trial has taken you almost 15 plus years to do.
Okay, yeah.
And then you're looking at funding for 15 to 20 years, because then you still got to analyze the data and all the rest of it. So you're talking about, tens of millions just to run the trial. So yeah, it's challenging.
Of course. Well, that's everything. Thanks very much, Ciaran. That was really, really interesting and very useful. And we'll make sure and link to all the resources in our show notes.
Yeah, absolutely, lads. Happy to chat, and more than happy to come back on if you want part 2.
Brilliant. Yeah,
definitely. Yeah.